Good morning, or afternoon, evening, wherever you all are joining us from. I'm going to go ahead and share my slides here. And so we should be able to see this. My name is Dr. Claire Wright. I'm an assistant professor of ophthalmology at the University of Tennessee in Memphis. I'm going to be talking to you all today about congenital glaucoma. Now, I want to preface this by saying although I'm a fellowship trained glaucoma specialist, the way we practice and care for these patients in this region is I primarily work and co-manage with a co-management strategy with my fellow pediatric ophthalmologists. And so I'm just going to preface this whole discussion by that. I do take care of these patients, but it's a team approach, and we'll cover that a lot here. So I have no financial disclosures. Our lecture objectives are to discuss epidemiology and clinical features of congenital glaucoma, review medical treatment for congenital glaucoma, and review surgical management for congenital glaucoma and how these management strategies differ from adult forms. I took a chance to review all of the submitted questions. For the most part, the questions sent to me ought to be answered with this lecture. So I've got a couple poll questions to start. Here's our first question. What are the components of the classic triad for primary congenital glaucoma? A, epiphora, B, photophobia, C, blepharospasm, D, corneal clouding, E, A through C, or F, A through D. Next question, which of the following statements is true? A, primary congenital glaucoma is associated with a defect on the PAX6 gene. B, the first-line treatment for primary congenital glaucoma is latanoprost. C, one should avoid using brimonidine in children due to the risk of central nervous system or CNS depression. Or D, the procedure of choice for primary congenital glaucoma is trabeculectomy. Third question, which of the following statements is true? A, patients having undergone surgery for congenital cataracts only need ophthalmic follow-up for the first year after cataract surgery. B, Peters anomaly is characterized by central leucoma and iris strands. C, the procedure of choice for glaucoma and Sturge-Weber syndrome is trabeculectomy. Or D, neurofibromatosis type 2 is associated with glaucoma. I'm liking the distribution of answers to these questions. It means we'll hopefully learn a fair amount in this PowerPoint. So I'm going to go ahead and proceed. Before I get started, I do want to plug the American Academy of Ophthalmology BCSC Basic and Clinical Science course glaucoma book. This is an excellent and up-to-date review of glaucoma, and the way I structure my presentation is actually taken after the glaucoma BCSC book. For us practicing in the United States and probably elsewhere, that you can get continuing medical education credits. The content of this book is what's tested on our ophthalmic knowledge assessment tests for our United States ophthalmology residents. There's QR codes linking to procedure videos. I'm not a paid consultant. I just love the book. And I want to say no to that opportunity. All right, so let's get into the presentation. We're going to talk about congenital glaucoma. So I always like to look at kind of a historical perspective. I looked on PubMed searching congenital glaucoma, and the first report I could find was from 1923, 102 years ago, a case series where that term congenital glaucoma, at least in our PubMed search, was first used. And I thought it was really interesting to look it over because some of the observations made by the patient's parents, caretakers, and the providers caring for these patients were interesting and really kind of very telling. And so I'm going to read a couple quotes from this, and I encourage you, if you're interested or curious, you can pull up this report. And so a couple direct quotes from the book. The mother said that at birth, the eyes protruded like marbles. The eyes were prominent and starry, pupils moderately dilated, the lenses cataractous, and the tension stony hard. It was almost impossible to open the child's eyes, and the moment the lids were pried apart, a gush of tears would come out. There's a white band across the dry and lusterless cornea below the center. It was impossible to ophthalmoscope this case, the cornea being too cloudy for that purpose. And then I looked over some of the enucleation reports, and some of the quotes in those reports were also interesting. The iris is exceedingly atrophic and thinned. And on section, there was an absence of the canal of Schlemm, and there was complete atrophy of the ciliary body. So we can learn a lot from looking back to see where we've come from, and we certainly have learned a lot in 102 years, but just trying to put myself in the shoes of those doctors back then, this was probably even much more difficult to care for than it is now. So in many ways, we're lucky. So moving on, how do we define pediatric glaucoma? Well, according to the Childhood Glaucoma Research Network and the World Glaucoma Association, you can kind of use this grid to help you. And so we'll start with, how is pediatric glaucoma defined? So that middle column. So pediatric glaucoma is IOP-related nerve damage and at least two of the following: IOP over 21, optic disc cupping or progressive cup-to-disc ratio increase, the presence of Hobbs stria or breaks in Descemet's membrane, enlarged corneal diameter, as detailed here. We'll get into all of these again. Visual field with a reproducible defect consistent with glaucoma, and myopia, progressive myopia, myopic shift, increase in ocular dimensions out of proportion to expected growth of the child's eye. How do we define pediatric glaucoma suspect? Well, you have no IOP-related damage plus at least one of the following: IOP over 21 on 2 separate occasions, optic disc appearance suggestive of glaucoma, such as an increased cup-to-disc ratio for the size of the optic disc, increased corneal diameter or axial length in eyes with normal IOP, and visual field suggestive of glaucoma. So it's kind of helpful to have a framework, or does this patient meet criteria for glaucoma or glaucoma suspect? How do we classify pediatric glaucomas? Well, these are classified as primary or secondary. Primary implies that the abnormalities are limited to the anterior chamber. So this includes primary congenital glaucoma and juvenile open-angle glaucoma. Secondary means that there are other associated ocular and systemic abnormalities from which glaucoma develops as a consequence, or secondary to the underlying ocular problem. So this includes Axenfeld-Rieger syndrome, Peters anomaly, Aniridia, Sturge-Weber syndrome, Neurofibromatosis type 1, and then also included in this group, I kind of lumped it in, as glaucoma that follows surgery for congenital cataracts. So we're going to talk about each of these. So a word on pediatric glaucoma genetics. Many of these, as we'll get into, have associated gene abnormalities. And so there are gene-based panels available. And the hope is that these, for these syndromes associated with a single gene mutation, this could be a potential site for future therapies. And then also this may be useful for patients who are, childbearing years, like thinking about building their family. And so, we can work with these patients, get them connected with genetics to counsel them appropriately about how they ought to understand the chances of passing these genetic defects on to their children. So we're going to first talk about primary congenital glaucoma. So thankfully, fairly rare, but we do see it. This occurs in about 1 in 10,000 to 1 in 30,000 live births. This primary congenital glaucoma does account for the majority of primary pediatric glaucomas. And 25% of primary congenital glaucoma cases, are diagnosed during the newborn period. 70% of these cases are bilateral. More than 75% are diagnosed in the first year of life. More common in males, and patients who have a sporadic form have a 2% chance of having a child with primary congenital glaucoma. More on the genetics. So primary congenital glaucoma, 40% of these cases are inherited in an autosomal recessive pattern. And there are gene defects associated with primary congenital glaucoma. The first one is the CYP1B1 gene located on the GLC3 locus. This gene encodes cytochrome P450 oxygenase, which is involved in the metabolism of retinol to retinoic acid, and involved in the anterior segment development and regulation of aqueous humor production and secretion. So if that's defective, it follows that you'll have anterior segment abnormalities. The other gene associated with primary congenital glaucoma is the LTB2 gene located on the GLC3C, GLC3D loci. This particular gene encodes for an extracellular matrix protein that's associated with cell adhesion and microfibrillar production. And so defect in that, you're going to have cell adhesion problems, which would have implications for the trabecular meshwork. Another gene associated with primary congenital glaucoma is the ANGPT1 and TEK genes located on the GLC3E locus. The ANGPT1 gene is associated with blood vessel lymphatic development. So abnormalities there, you're going to have abnormalities of blood vessels and lymphatics, which would have implications for the drainage area, the angle. And so, you know, it follows that problems with these genes would have implications on patients with problems with the angle. And so, what is the pathophysiology of primary congenital glaucoma? Well, we don't know the exact pathogenesis. There was a thought, Dr. Barkan back in the day thought there was perhaps a membrane obstructing the flow of aqueous through the angle, but that's never been identified. Most likely, this is an arrest of neural crest cells that are responsible for angle development. So there's this photo which demonstrates there's 3 waves of neural crest cell development in the eye. And an aberration of any of these waves is going to have effects, result in intersegment dysgenesis, most likely glaucoma eventually. So what are the clinical features of primary congenital glaucoma? There's a classic triad: epiphora or tearing, photophobia, and blepharospasm. That's a classic triad, commonly tested on, you know, board exams, OCAPs, and clinically relevant, as you can see in this picture. Other findings associated with primary congenital glaucoma include high pressure, which results in a number of findings. So enlarged corneal diameter, globe enlargement, aka ophthalmos, or translated to cow eye, which is increase in axial length, was resultant in progressive myopia. You can get breaks in Descemet's membranes, which are called Hobbs striae, and corneal clouding, and as well as eventually optic disc cupping. So these are the clinical features of primary congenital glaucoma. Pictures here, the picture on the left demonstrating Hobbs striae, and the photos on the right, demonstrating a pretty significant ophthalmos. When we see a patient coming in, you're like, oh, this looks like congenital glaucoma. Well, we got to step back and make sure it's not something else. So practice the differential diagnosis. And so what your differential diagnosis is varies depending on the presenting symptom. And so if you're seeing a patient with corneal clouding, the differential diagnosis is, you know, the mnemonic is stumped, scleral cornea trauma, ulcer, mucopolysaccharidosis, Peters anomaly, congenital endothelial dystrophy dermoid. This is a useful mnemonic to think about. Hey, what else could it be that's, you know, not congenital glaucoma? Patients coming in with epiphora or tearing. Is it a nasolacrimal duct obstruction, epiblepharon, conjunctivitis, corneal abrasion, uveitis? And so you got to make sure it's not these other things. Is a patient coming with corneal enlargement? Well, it could be congenital glaucoma or megalocornea, axial myopia, craniofacial dysatosis with shallow orbits. And then if you have a patient that you're seeing optic nerve abnormalities, of course it could be congenital glaucoma, but also like disc pit, coloboma, optic nerve hypoplasia, physiologic cupping. And so the way you kind of fill out this differential diagnosis depends on the presenting symptom or sign. So how do we manage these patients? And we are going to get into this again later. We'll talk about meds and we'll talk about surgeries, but just taking a step back, many times these patients are presenting as infants or babies or toddlers, and these patients need many times an examination under anesthesia for a comprehensive assessment. And the treatment is primarily surgical. Medications can temporize and improve corneal clouding for surgery, but these patients need surgery. Contrast this with juvenile and adult forms of glaucoma. And first-line treatment is many times laser or medications, and surgical options can be used later in the treatment course. And that's because, as far as my understanding is, well, the angles are developmentally normal, usually in these cases. And so you've got more to work with. There's a little more wiggle room, versus a congenital glaucoma, the angle never developed normally. So let's talk about JOAG, or juvenile open-angle glaucoma. So this is a form of primary open-angle glaucoma that presents between 4 and 40 years of age, and mostly inherited autosomal dominant. Patients present with elevated IOP, but not usually with Hobbs striae or corneal enlargement, because this is presenting later. They can have axial elongation and progressive myopia, and so there is still kind of the wall of the eye, the sclera is still kind of malleable, but not as malleable and subject to change as the eyes of infants. So that's why you can have axial elongation, but not as much the corneal enlargement, ophthalmos, etc. First line treatment, at least according to the BCSC, is medical. And so you can start the drops, and we'll get into the drops, but it's really for refractory cases, you can think more surgical options. So we're now going to talk about the secondary pediatric glaucomas. And so these are glaucomas associated with various ocular, with or without systemic abnormalities. And so this includes Axenfeld-Rieger syndrome, Peters anomaly, Aniridia, Sturge-Weber syndrome, Neurofibromatosis type 1, and then also includes glaucoma following surgery for congenital cataracts. So let's talk first about Axenfeld-Rieger syndrome. So this is a spectrum of diseases characterized by an anomalous anterior segment. It's bilateral, typically no sex predilection, and the classic clinical presentation is this posterior embryotoxin of the cornea, as that top photo shows. This is an anterior displaced Schwabe's line, and so you see in that photo, there's that kind of white ring just kind of in front of the limbus. That's the posterior embryotoxin. You can also have iris adhesions and iris abnormalities. Iris abnormalities can include hypoplasia, chorectopia, or displacement of a normal pupil, polychoria, multiple pupils, and or ectropia and UVA. So the bottom picture demonstrates polychoria, chorectopia, just so it looks like also iris hypoplasia, so kind of a picture that shows it all. These patients, Axenfeld-Rieger patients, can also have systemic signs, and so you can see developmental anomalies of teeth or facial bones, such as kind of rudimentary teeth, maxillary hypoplasia. They can have redundant periumbilical skin. Now, I'm not like lifting up kids' shirts to look at their belly button or anything. Let me just say that. But you could ask, if you suspect a child has that, you can ask, hey, is there any abnormalities elsewhere in the body? And probably an observant parent would note this. Periumbilical skin, hypospadias, and pituitary abnormalities. So 50% of Axenfeld-Rieger syndrome patients go on to develop glaucoma. Typical onset is middle to late childhood. And this is thought to be due to abnormal development of the angle. It just presents later than primary congenital glaucoma. The treatment is the same as open-angle glaucoma, although angle-based surgery may not be possible due to iris adhesions. And so we'll get into angle surgery, what that is, different parts of that later. We're going to talk next about Peters anomaly. This is a developmental disorder characterized by a corneal opacification, aka glaucoma, in the central visual axis, as this photo demonstrates. These cases are typically sporadic and most often bilateral. And the classic clinical presentation is that glaucoma, that central corneal opacity, with iris strands to that glaucoma. And there's also an absence of the corneal endothelium, decimase, membrane, and posterior stroma corresponding with the glaucoma. These patients can sometimes have a cataract with corneal lenticular adhesions. This is a photo demonstrating bilateral Peters anomaly. So patients with Peters anomaly, 50% will have developed glaucoma. And the rate is higher in those with cataracts and corneal lenticular adhesions. The glaucoma is thought to develop due to abnormal angle development with the contribution to peripheral anterior synechia if those are present. But you can also develop glaucoma secondary to ocular procedures required for Peters, such as penetrating keratoplasty, cataract surgery, and the use of steroids for post-op management for those procedures. And treatment for Peters anomaly, you can certainly use many times refractory because the angle is abnormal. There's a lot going on in the anterior segment, iris adhesions, etc. So you can start, if you've got a view, you can start with angle surgery or start with trabeculotomy, which we'll talk about. You may need to move on to larger glaucoma procedures such as trabeculectomy and tube shunts. And we'll talk about the surgical options. I'm going to talk next about aniridia. This is a bilateral disorder characterized by iris hypoplasia of varying amounts. So you can have a patient where it looks totally normal on phos view and the slit lamp, but then you get into retroillumination, you're like, oh wow, you see a lot of that red reflex through that iris because it's a little bit hypoplastic. And then there are patients who have almost no iris and just rudimentary stumps. And so the spectrum is broad. Clinical features of aniridia include, as I mentioned, iris hypoplasia, and with or without microcornea, limbal stem cell deficiency, which can result in gradual corneal opacification, as that second photo shows, the bottom one, anterior polar cataract, optic nerve hypoplasia, and foveal hypoplasia. We need to talk about kind of genetics of aniridia. 66% of cases are inherited autosomal dominant, but the remaining third of cases occur sporadically due to a mutation in the PAX6 gene. And 20 to 30% of sporadic cases are associated with a Wilms tumor gene mutation. And those patients have a high chance of developing a Wilms tumor. So that's in the kidney. This is an abdominal ultrasound demonstrating a Wilms tumor. So it's really important to ask, these patients and their families, hey, is there family history of aniridia? You could look at other children, look at the parents, and if there's not, you better get an abdominal ultrasound because, this could be, if this is a sporadic mutation, then there's a solid chance it could have a Wilms tumor. Aniridia can have kind of other systemic abnormalities, and there's syndromes. The WAGR syndrome is autosomal dominant, associated with Wilms tumor, aniridia, GU abnormalities, and mental retardation. And then there's also Gillespie syndrome, which is autosomal recessive and characterized by cerebellar ataxia, aniridia, and mental retardation. So really, it's that WAGR syndrome that you want to kind of have your ears perked up for if you are making the diagnosis of aniridia in what it looks like a sporadic case. So aniridia, glaucoma in aniridia occurs in 50 to 75% of cases. The time frame is variable, so if presents early, it's thought to be due to maldevelopment of the angle structures. The treatment of glaucoma is similar to other forms of these kind of pediatric glaucomas, and if you can do an angle-based surgery such as goniotomy or trabeculotomy, you should do it, but you may need to use larger incisional glaucoma surgeries. But you also, for these patients, really important to remember clinically and on boards is you have to remember to treat or refer out other associated conditions. And so I mentioned cornea can be associated with limbal stem cell deficiency, so you got to look for that. Recommend lubrication. They might need to get amniotic membranes or limbal stem cell transplant. Glaucoma, we talked about, you treat that. If they've got that WAGR disorder, well, you better monitor for Wilms tumor with an abdominal ultrasound or work with the pediatric team. Many of these patients have hearing loss, so refer out to audiology, and then there's an inheritance pattern, and so you work with genetics to counsel the patient eventually on how and parents on family planning if interested. I'm going to talk next about Sturge-Weber syndrome. So this is also known as encephalofacial angiomatosis. This is a phakomatosis characterized by a facial cutaneous hemangioma or port wine stain, which is what that top photo shows, ipsilateral choroidal cavernous hemangioma, ipsilateral leptomeningeal angioma, and cerebral calcifications. And so these patients have systemic manifestations many times, including seizures, neurological deficits, and cognitive impairment. The bottom photo is supposed to demonstrate, pretty kind of corkscrew episcleral vessels, kind of implying there's congestion of the vessels around the conjunctiva episclera. Sturge-Weber syndromes have about 30 to 70% incidence of developing glaucoma. This is a bimodal age distribution where close to 2/3 present 0 to 3 years of age, and the remainder present later in life. And this bimodal distribution probably implies that those presenting early in life have an angle anomalies or dysgenesis, intersegment anomalies, dysgenesis, never develop normally. And then the second could be due to, the later in life could be due to increased episcleral venous pressure. And so glaucoma is more likely to occur if any of the following are present on exam: cutaneous hemangioma of the upper eyelid, episcleral hemangioma, iris heterochromia, and choroidal hemangioma. So we look for these things. Unfortunately, the success rate for glaucoma treatment in Sturge-Weber syndrome is lower than that of primary congenital glaucoma. These patients have a high risk for choroidal hemorrhage with incisional glaucoma surgery of any type. And so typically tube shunts are preferred over trabeculotomies. And, for intraoperative considerations, you can consider making scleral windows, avoid a large pressure differential. So really work on IOP control before you bring them to the operating room. Because if you get a high pre-op pressure and then a low post-op pressure, a high chance that they'll get a choroidal hemorrhage. I also got a pearl from one of my mentors in fellowship is leave a fair amount of ophthalmic viscoelastic device in the eye, in the anterior chamber, before you finish surgery. So to, again, reduce that pressure differential to minimize the risk of choroidal hemorrhage. Next, we're going to talk about neurofibromatosis type 1. And so neurofibromatosis is the most common phakomatosis. It's divided into type 1 and type 2. Type 1, which we'll talk about, is aka peripheral phakomatosis, and type 2 is central phakomatosis. So this is type 2 is like acoustic neuromas. And that type 2 is not associated with glaucoma. So neurofibromatosis type 1, or NF1, 50% of cases are inherited, autosomal dominant, and 50% are sporadic. NF1 is a tumor suppressor gene. So an abnormality in the tumor suppressor gene, you're going to get tumors. And so what do you see? The ocular findings are these leash nodules, the little iris kind of lumps and bumps in that second photo. Those are leash nodules. You can see also ectropion uvea, choroidal lesions, optic nerve gliomas, eyelid neurofibromas, which is what that top photo shows, and also glaucoma. Now, thankfully, there is a low incidence of associated glaucoma in NF1, but if patients have an eyelid neurofibroma, that incidence, the risk of glaucoma development actually increases if they have an eyelid neurofibroma. And the pathogenesis of glaucoma depends on age of glaucoma presentation. So at birth, most likely due to angle dysgenesis. Later in life, probably related to angle infiltration with that neurofibromatosis tissue, or secondary angle closure due to thickening of the ciliary body or choroid from that neurofibromatosis tissue. Treatment of glaucoma in NF1 is typically surgical, although less successful than primary congenital glaucoma cases. I want to talk next about glaucoma following surgery for congenital cataracts. So risk factors for patients who develop glaucoma having undergone cataract surgery for congenital cataracts include cataract surgery in the first year of life, particularly the first 6 weeks of life. If they've had any postoperative complications, if they have a small corneal diameter relative to age-appropriate values. And this risk of developing glaucoma is independent of whether these patients are left aphakic or if they have an IOL implanted at the time of cataract surgery. And so this, another name for this, it's a little archaic, it's kind of being phased out as aphakic glaucoma. Not really exactly accurate because a lot of surgeons, at least in this country, put an IOL in the time of cataract surgery. So aphakic glaucoma is another word for this, but I just use a longer term, glaucoma following surgery for congenital cataracts, a little more specific, a little more accurate. What are the proposed pathophysiologies of developing glaucoma after surgery for congenital cataracts? Well, could be related to congenital anomalies of the aqueous outflow, could be related to post-op inflammation, and it could just be that it's not normal in a human to have cataract surgery as a child or a baby. So like fundamentally altering that ocular anatomy post-cataract surgery, maybe something there results in glaucoma. We don't know exactly, but there are these proposed pathophysiologies. Many times these angles are open. And this is a very important point. Patients who have undergone cataract extraction for, it should say congenital cataracts, not congenital glaucoma, require lifelong monitoring for glaucoma. So you diagnose a child, a baby, with congenital cataracts, you do the cataract surgery, you need to monitor them for life for glaucoma development. You can't just sign up and say, see you later. You got to monitor for life. So how do we evaluate the pediatric glaucoma patient? Well, first and foremost, you got to get a good history. And so talk to the parents, talk to the caretakers, ask about mother's gestational history. Did she have any intrauterine infections? Did she get regular prenatal care? How was it delivery? Was it C-section? Was it vaginal? Was it complicated by anything, forceps, and things like that? How has the patient's developmental milestones been? Have they been meeting their milestones? Have they been regressing? Do they have a family history of glaucoma, eye diseases, consanguinity? History of consanguinity increases the likelihood of developing primary congenital glaucoma and other diseases. What is the patient's prior ocular medical surgical history? Have they been on medications before? Not just glaucoma medications, but steroids. What's their behavior like? Do they act like age appropriate compared to their peers, compared to older siblings? Are they irritated? Are they eating okay? Like what Are they navigating a room okay? Do they bump into things? You can get a lot from parents' report. Really, the history is so important in pediatric glaucoma patients. And do the caretakers notice anything weird? Kind of squinting of the eye, tearing, sensitivity to light, things like that. All right, so how do we evaluate the pediatric glaucoma patient? Of course, check age-appropriate vision, visual acuity. External exam, which kind of includes like looking at the patient from across the room, and the chair and the lids, is, well, do they have evidence, like frank evidence of ophthalmos, like epiphora, blepharospasm? Do they have any systemic findings that you can see from across the room, such as phakomatosis, that eyelid neurofibroma? What's their behavior like? Are they playful? Are they agitated? Are they able to navigate that exam room? All right, so now we'll talk about what do you look for in an anterior segment. And again, low threshold to perform an examination under anesthesia. That's usually where the direction it goes depending on the child's age. But if you've got a lot of finesse in the pediatric exam room, what do you look for? So corneal diameter is going to be enlarged in patients who likely have congenital glaucoma. So if it's over 11 in a newborn, over 13 millimeters at any age, it's highly suggestive of glaucoma. And then you look for the corneal clarity, and are there hauptstria? Check eye pressure, of course. Now, in our population here, many times we rely on rebound tonometry because you don't need to put numbing drops in, although it's traditionally less accurate than Goldman and Perkins. During examination under anesthesia, very important to check IOP immediately after induction of general anesthesia and before intubation if possible, because all of those anesthetics, those medications given by the anesthesia team for putting them to sleep are going to drop the pressure. And so you want to get as accurate pressure as possible from the onset. And typically I'm using tonopen, before the patient's intubated. And then I recheck after intubation. And so also obtain a pachymetry, normal pachymetry in pediatric populations of 540, 560, that range. And so if it's thick, that could imply that there's corneal edema, or that can, of course, have implications on IOP measurements. Now, gonioscopy. Good luck doing gonioscopy on a child in clinic. So this is primarily during examination or under anesthesia. So what's the normal infant angle look like? Well, typically less pigmented trabecular meshwork, less prominent Schwabi's line, and less distinct junction between ciliary body, band, and scleral spur compared with adults. So kind of just overall, a little bit harder to differentiate landmarks. In the primary congenital glaucoma angle, you tend to have a deeper anterior chamber, high anterior iris insertion that can obscure the view of the scleral spur. So this photo is, and it's hard to get gonioscopic images in general, but harder in children, more difficult in children. So this is a photo demonstrating a kind of partially obscured scleral spur. The white line scleral spur is a little bit difficult to visualize, most likely because of high iris insertion. The angle in a juvenile open-angle glaucoma patient is usually normal. And just want to make a note back to aniridia. If you do gonioscopy, many times you can see an iris stump. If they look like they have no iris, well, they probably have an iris, and you can see it on gonioscopy as a stump. Optic nerve exam, of course, is so important in all glaucoma patients, including the pediatric glaucoma patient. And so typical cup to disc ratio in infants is less than 0.3 and should be symmetric. Now, this cup to disc ratio does increase slightly until 10 years of age to about but this cup to disc ratio varies by ethnicity, and you have larger cup to disc ratios in patients of African, Middle Eastern, Hispanic, and East Asian descents. Now, what's interesting is that, say you've got a patient you've diagnosed with congenital glaucoma and you started treatment, did surgery, whatnot, cupping can be reversible if IOP lowering is initiated before 3 years of age. So that's very interesting. So sorry, I just got distracted with something. Okay, so cupping can be reversible with initiation of treatment at early age. And then patients with primary congenital glaucoma typically on nerve fiber layer assessment exhibit diffuse RNFL loss rather than localized to the superior and inferior poles. And that's in contrast to adult forms of glaucoma. So it's typical diffuse loss, diffuse kind of symmetric cupping of the optic nerve head as opposed to kind of involvement of the superior and inferior poles. So this photo is just demonstrating asymmetry of a cup-to-disc ratio. So if you have cup-to-disc ratio asymmetry greater than 0.2, that's concerning for glaucoma. Other testing you can perform for pediatric glaucoma patients: cycloplegic refraction. You're checking for myopia. You're monitoring with cycloplegic refractions to watch for progressive myopia, which would imply axial elongation from high pressure. A scan to measure axial length. We do in the kind of the management strategies, co-management strategies I have with my pediatric ophthalmology friends here. Part of the standard EUA, examination under anesthesia, is getting A scans, and we compare the axial length to the previous axial length and see, hey, has it changed more so than you'd expect for the change in age? And so we monitor that. You can try to get visual field testing in children, age appropriate. Usually, if try to wait until the patient's 6, 7 to try a Humphrey visual field. Depends on how mature they are, and so that just kind of play it by ear depending on the patient's maturity level. And then if you can get nerve fiber layer imaging, that'd be great too. But you do have to remember the normative database for children is not, it doesn't exist in commercially available platforms. And so we look at kind of those, global thickness scores, kind of trend, green, yellow, red, and that's all compared to a normative database of adults. And so you kind of have to almost just look at the global thickness scores, or the scores of the different sectors of the nerve, and almost just like subtract from your brain like the colors, because you can get fooled, and look for change over time. What's important, and I learned this when I was preparing for this lecture, is that RNFL thickness for children over 5 is actually comparable to that of adults. And so maybe if you got a kid over 5, 6, 7, and then you can kind of look at the colors a little bit. But just in general, you look really for kids, you just have to remember, look at the global thickness scores and look for change over time. Other thing I wanted to mention on the visual field testing is that there are not really age-adjusted corrections for visual field. So if you're doing a Humphrey in a child that can take a Humphrey visual field, the mean deviation is not really affected. It's like less than 1 decibel per 10 years of life. There's not really much influence that age has on the visual field measurements, basically. And so just get it when you can, and you just wait to get it until they can take it. There's other ways you can test visual fields in children. There's kind of fun pictures on the internet, but I try to just usually wait for Humphrey. All right, so how do we manage congenital glaucomas? We kind of got into it a little bit, but we're going to get into more details now. Again, management is primarily surgical in primary congenital glaucoma and early onset pediatric glaucomas, but you can use medications to temporize and reduce corneal clouding, which would improve potentially the view enough to perform a gonioscopic lens-assisted surgery, which we'll talk about. So for temporizing with medications, we have to keep in mind the patient's age and comorbidities when choosing which medications to start. So drug classes you can use with caution. Beta blockers you can use, usually start with like a low dose, but you have to make sure they don't have concomitant cardiac or pulmonary dysfunction, i.e. asthma, because that can exacerbate wheezing. Of course, we know about bradycardia. And so you start at the lowest concentration. I usually do 0.25 timolol. Adult dose is 0.5%. You start with pediatric dose, 0.25. You can also do cardioselective medications like levobinolol, cardiolol. Typically, my first line is beta-optic or 0.25% timolol. And then talk about punctal occlusion to the parents. Basically apply pressure to the punctum 2 to 5 minutes after drop installation. It'll mitigate the risk of systemic absorption of the medications, all of these medications. You can use carbonic anhydrators, anhydrase inhibitors. Topical preparations such as dorzolamide, brinzolamide, available in this country, are fine. Be very careful with systemic preparations such as acetazolamide, methazolamide, because these have so many side effects. GI upset, anorexia, diarrhea, weight loss, hypokalemia, risk of sickle crisis. I just try to avoid systemic carbonic anhydrators inhibitors in children, so just topical. You can use prostaglandin analogs. It's especially useful in juvenile open-angle glaucoma, and older children tend to respond better to this class of medications than younger children. And so in our country, we've got latanoprost, imatoprost, travoprost, and the like. All right, so you must avoid alpha adrenergic agonists in children under 2. This is brimonidine, aproclonidine, and alpha AMP in this country because of the risk of central nervous system depression. You can get hypoxia, altered mental status. You should also proceed with caution in children under 6 in general and who are of weight less than 20 kilograms. I avoid this in all kids, as I put it off for as long as possible. And maybe the youngest patient I have on this is like 8 years of age. But you just don't want to run the risk of central nervous system depression. And if you are starting this, talk about nasolacrimal occlusion or punctal occlusion. What about these other drug classes? Drops primarily. Well, we've got the parasympathomimetic agents such as ecothiopate iodide, which is actually, there's like a small but pretty, small group of individuals who really respond well to this medication. And these is like kind of refractory glaucoma cases, a congenital glaucoma. But it does have associated irisis, inflammation, and the like. It's like gone on and off the market in our country, and so anytime its existence is threatened, we have a very vocal group of people who say, this is the only medicine that works for my patient. We got to keep it available. So that's kind of been an interesting thing to follow in my practice. There's also direct parasympathomimetic agents such as pilocarpine. It's kind of not used as often because at least in this country, because of intense dosing schedule required 3 to 4 times a day, does have associated myopia, risk of retinal detachment. I've also seen with prolonged use of pilocarpine, just, it causes miosis, and the people can stay that way. It causes artifacts in visual fields and affects vision, and it makes it, eventual cataract surgery challenging because of need to expand the pupil surgically. And so I usually don't use pilocarpine in general in any patient. So Rho kinase inhibitors such as notarsidil in this country, there's not a lot of data available, can be cost prohibitive. I do use it kind of as refractory treatment leading up to surgery. So here's a sample. We need to do surgery. Anyway, so you can start this. So congenital glaucoma surgical management. First line therapy is angle-based surgery. And so this includes goniotomy or trabeculotomy, and which surgery depends on how clear the cornea is. And so if the cornea is clear, that means you can get a view of for an ab interno approach, you can do goniotomy. If the cornea is cloudy, despite best efforts to clear the cornea with IOP control, you can do ab externo trabeculotomy. Angle-based surgery has a pretty good success rate, 70 to 80% chance if the infants are diagnosed within a particular window of time. 3 to 12 months is kind of that magic window of time where you get that diagnosis during that time, do these procedures, and they have a pretty good success rate. And you can perform these procedures, a couple times. Second line therapy, if you've tried those other things, trabeculectomy or tube shunts, and refractory cases, diode laser. We're going to talk about each of these. So first I'm going to talk about goniotomy. This is ab interno incision of trabecular meshwork tissue utilizing a blade or needle. And the angle is visualized via gonioscopic prism, as you can see in this photo. You can only do this if the cornea is clear. It's obvious. You got to see what you're treating. And if you don't have a clear cornea, you can't do goniotomy. And then also considerations for goniotomy is, those landmarks are going to be kind of funky and distorted, especially if the patient's got ophthalmos. And so just something to keep in mind when you're performing this procedure. Risks of goniotomy include hyphema, infection, iris lens damage, eventual cataract formation, and uveitis. I want to talk next about trabeculotomy. This is cannulation of Schlemm's canal. You can do it ab externo, so from the outside in, or ab interno. So you can decide if you got a clear cornea, you can do this or goniotomy. I think goniotomy is a little technically easier. So what trabeculotomy consists of is you get access to Schlemm's canal, and then you use an instrument, be it a trabeculotome, 6-0-proline suture, microcatheter, and you thread it through the Schlemm's canal. You can go 360. Once you get it all the way through, then you can take the ends and pull it, and then you can basically create an opening. Basically you kind of shred the trabecular meshwork, so there's an opening from the anterior chamber to Schlemm's canal. So this is in adult patients. We also call this gonioscopic assisted transluminal trabeculotomy, or GAT, if you're doing it ab interno. Omni is another device used in this country, which accomplishes a similar thing. Again, it's cannulation of Schlemm's canal, and then you can perform essentially a goniotomy. You want to be careful about creating false passage, something to keep in mind while you're doing it. And the risks of this procedure, like goniotomy, hyphema, infection, iris lens damage, iris damage and lens damage, and uveitis. So say you've already performed a couple angle-based surgeries and the IOP is back up, what do you do now? Well, you got to think about trabeculectomy or tube shunt. Now, how do you choose? Well, there's a lot of things to consider. You got to think about the age of the patient. So success rate for trabeculectomy is low in children under 2. Ability to follow up regularly. I mostly care for adult patients, and even in my adult patients, I'm very careful about who I perform a trabeculectomy in because that post-op bleb management is pretty intense and requires close follow-up for serial injections of 5-fluorouracil, laser suture lysis, so it's very intense follow-up. What's your IOP goal? You get lower pressures with trabeculectomy versus tube shunts. What are their concomitant eye diseases? Do they have a condition where their sclera is really thin, in which case you probably would be very hard to make a scleral flap, as you do in trabeculectomy? What's their lens status? Now, if they are aphakic, you do have a lower success rate for trabeculectomy in those patients. And what's their behavior and lifestyle? I mean, if the patient has, a history of eye rubbing, that's just one example, I probably wouldn't do either of these procedures because of the risk of infection, probably proceed with diode. But one thing that I want to bring at this point, this is for an adult patient I had, she was given a recommendation for trabeculectomy, came to me for a second opinion, and she was like, listen, I swim a lot, water baby during the summer. I don't want a trabeculectomy because it would really alter my hobbies. And so I think I did something else for her, but that's just, you have to ask these questions so you can make an appropriate management decision for your patients. So trabeculectomy is where you bypass trabecular meshwork via creation of a scleral flap. You utilize antifibrotic agents to increase the success rate. Proceed with caution in young children. I mentioned if you do this in children under 2, a higher risk of failure, but also you do have a risk of infection, and which is increased with the use of antifibrotic agents. So they help success with the procedure, but you run the risk of infection. This actually, trabeculectomy can be combined with trabeculotomy. And so the thought behind this is that it would this combined procedure reduces resistance to the trabecular meshwork and enhances outflow via filtration. And then there is a higher rate of success with trabeculotomy and trabeculectomy versus standalone trabeculectomy. And so especially, if you're trying to get, maximize your OR time, so to speak, this is a child, good candidate for trabeculectomy, over 2 and things like that. Maybe you just do a combined procedure while you're in the OR, and then you may have a higher rate of success, at least according to, some of the things I read. Risk for trabeculectomy, bleeding, infection, namely blebitis, infection of the bleb, endophthalmitis, scarring of the bleb, and cataract. Let's talk about tube shunts. So we all hopefully know what tube shunts are, but this is an implant that shunts aqueous to an external silicone plate reservoir. There's valved and non-valved. In this country, Ahmed versus Beerveld. Ahmed ClearPath is another non-valved shunt available in this country. The risk of infection in tube shunts is lower compared with trabeculectomy, but you don't get as much IOP reduction, and there's more long-term dependence on glaucoma drops than for the patients who've undergone a trabeculectomy. When you're doing a tube shunt, you do have to keep in mind, if you're doing a tube shunt in a child, what's their axial length? Because you got to be careful that you don't put that tube shunt too close to the optic nerve. And so there's this, I misspelled it, sorry, it's a calculator available, I think it's via Duke University, the Friedman Margetta glaucoma drainage device online calculator. So it's very useful. You put in the quadrant that you plan to put the tube shunt in, axial length, the distance you want the plate to be from the limbus. Usually I shoot for 8. And then it tells you if you need to trim the back portion of the plate at all to mitigate damage to the optic nerve, and it tells you how much. So it's really useful. I use it all the time. Risks for tube shunts: bleeding, infection, double vision with due to effect of the potentially damage to the extraocular muscles or effect of that the plate develops encapsulation around it. Sometimes if that encapsulation is prominent or there's a tenon cyst, that can abut and affect the optic nerve, or excuse me, the extraocular motility. This is an implant, so you can have the risk of device exposure migration, cataract formation, and corneal decompensation. If you're putting the tube shunt into your chamber and it's too anterior or migrates, it can touch the cornea and cause decompensation. Next, we'll talk about diode laser. So typically reserved for refractory cases, the kind of tried and true old school cyclophotocoagulation, or the G6 probe we use in this country, is difficult to titrate. So you can actually use, if you're going into the eye for cataract surgery, you can perform endocyclophotocoagulation at the same time to actually directly treat those ciliary body processes. That's titratable. Or you can use this new kind of more recent micropulse laser, the MP3, which we've had about 10 years, close to 10 years in this country. And both the endocyclophotocoagulation and micropulse laser are less inflammatory and more titratable, less chance of hypotony, less chance of inflammation. So all of these lasers, there's a risk of inflammation, hypotony, retinal detachment, ptysis, and vision loss. But especially those risks are pertinent to the cyclophotocoagulation laser. In this country, we don't really use cryo laser much anymore for glaucoma management, so I didn't talk about that. Now, what's the long-term prognosis for congenital glaucoma? Well, I kind of got to it a little bit, when comparing primary congenital glaucoma to other secondary pediatric glaucomas, but primary congenital glaucoma has a better prognosis than most secondary pediatric glaucomas. 2/3 of patients with primary congenital glaucoma have 20/70 or better vision. Hey, that's functional. That's great. They can live a close to normal life with that. Maybe they can't drive, but they can, go to school, work and whatnot, maybe with some accommodations, but that's functional vision. The best prognosis for primary congenital glaucoma is for those diagnosed between 3 and 12 months. These patients typically do well with angle-based surgeries. I mentioned that already. Now, poor prognosis for patients with primary congenital glaucoma are those who were diagnosed as a newborn, those who are diagnosed after 1 year of age, and those with large corneal diameter greater than 14. You do have to, when you're counseling the patient and family on long-term prognosis, better watch out for other ocular morbidities, including but not limited to amblyopia, corneal scarring, strabismus, cataract formation, and IOL subluxation. I didn't include posterior capsular opacity, but things like that. It's not just the glaucoma. So how do you counsel these patients and parents? Emphasize the need for lifelong glaucoma care. This is a long road, and you're counseling the patient, you're also counseling yourself, so this is a long road. This is a marathon. It's not a sprint. Use whatever kind of turn of phrase kind of speaks to the patient, but this is a long road, and expect it is normal. You are going to have multiple surgeries in your life to control your pressure, but I'm here for you. We're going to take care of it together. So the way you counsel the patient, you're counseling the patient, you're also counseling yourself. These are not adult patients. There's a different can of worms. Remember to refer these patients as appropriate to for their associated systemic disease. And so I mentioned, earlier, Wilms tumor association with aniridia and other syndromes. And so make sure, you're a physician. Many of us are physicians on this call. We're treating the whole body. Like, remember, it's more than just the eyeball. And utilize low vision services if available and when needed. I have a very low threshold too. We're very lucky in Memphis. We have a large school of optometry, Southern College of Optometry, that has a low vision department. And so I very commonly refer patients there, and they work with them to optimize their function. And so, my job is to, of course, ensure the disease is stable, but you also want to help them see better, help them make the most of what they have with their vision and improve their quality of life. And so we work with low vision. And then, of course, I remind patients and families that, I'm available as a resource to help. And so that availability, that resource includes communication with other services such as genetics, coordination with school systems to fill out necessary paperwork, to develop independent education plans based on vision limitations, communicate with patient employer on vision limitations and need for serial ophthalmic exams, procedures. And so this can include, in our country, filling out FMLA paperwork and sometimes disability paperwork. And so I give it to the patient and their family. Hey, I'm here for you. Apart from working with genetics and low vision consultation, any of this, paperwork, you need me to fill out, I'll do it. Just bring it to me. So, and I emphasize that a lot. So that's really the bulk of the presentation. I do want to give a final plug and say, these patients require like a village to take care of. And so I'm very lucky I'm able to co-manage these patients with my pediatric ophthalmology service. I also have mentors. I did my fellowship up in Boston. I have wonderful mentors in doctors David Walton and Helen Young in Boston who take care of many of these patients. So almost every time I have one of these cases, hey, this is my plan, running things by them, getting their insight. And they've been so encouraging of me in this kind of care for these complex patients. But for those without kind of feeling alone, you don't feel alone, because CyberSight has actually, this platform has free consultation services where you can type in a question, send all the information, and I'm one of the mentors available to offer consultation in terms of next steps in patient management, because these are complex patients and sometimes you just need to run things by someone else to make sure you're not missing anything. And so I understand that. Please use this tool. All right, so last thing is we're going to review the poll questions. So question number 1, what are the components of the classic triad for primary congenital glaucoma? A, epiphora, B, photophobia, C, blepharospasm, D, corneal clouding, E, A through C, or F, A through D. Most of our responses, correct answer, the classic triad is epiphora, photophobia, and blepharospasm. Great. Next question. Which of the following is true? A, primary congenital glaucoma is associated with a defect on the PAX6 gene. B, the first-line treatment for primary congenital glaucoma is latanoprost. C, one should avoid using brimonidine in children due to the risk of central nervous system depression. Or D, the procedure of choice for primary congenital glaucoma is trabeculectomy. Which of the following is true? All right, this makes me really happy. The correct answer is one should avoid using brimonidine in children due to that risk of central nervous system depression. Very good. Last question. Which of the following statements is true? A, patients having undergone surgery for congenital cataracts only need ophthalmic follow-up for the first year after cataract surgery. B, Peters anomaly is characterized by a central leukoma and iris strands. Leukoma means kind of whitish opacity of the cornea. That's what leukoma is. C, the procedure of choice for glaucoma and Sturge-Weber syndrome is trabeculectomy. Or D, neurofibromatosis type 2 is associated with glaucoma. Which of the following is true? The correct answer here, the correct statement is Peters anomaly is characterized by central leukoma and iris strands. So, and I meant to kind of go through the other answers, but so patients who have undergone surgery for congenital cataracts, I apologize, the phrasing isn't quite grammatically correct in English. So patients who undergo cataract surgery as children, they need to be monitored for life for development of glaucoma. The procedure of choice for glaucoma and Sturge-Weber ought to be tube shunt, because you got to really be careful for suprachoroidal hemorrhage. And D, it's actually neurofibromatosis type 1 that's associated with glaucoma, not type 2. So great. These are my references. Thank you. Again, available as a resource. Here's my email, but I'm also one of the glaucoma mentors on the CyberSight platform. Okay, so I'm going to read through some of these questions. So best option for clear. Okay, so a lot of these we've kind of answered. Congenital glaucoma treatment, if there's a hazy cornea, surgically, trabeculotomy ab externo. Can we treat closed angle glaucoma with medication? Sure. Yeah. With the medications I've mentioned, timolol or beta blockers, carbonic anhydrase inhibitors, latanoprost, or prostaglandin analogs. Yeah, but just watch for comorbidities. What is the visual prognosis for congenital glaucoma? We kind of talked about that already. If diagnosed between 3 and 12 months of life, most patients have 20/70 or better vision. What type of laser can we use for congenital glaucoma? We can use diode laser, micropulse laser, endocyclophotocoagulation. I'm not sure about SLT, honestly, because selective laser trabeculoplasty or argon laser trabeculoplasty, because the angle is anomalous, and so I wouldn't think it would respond well to that. Can congenital glaucoma be diagnosed in utero? That's interesting. I think I have seen ultrasonic images of patients with like ophthalmos in utero. And so kind of hard to confirm what it is until they're ex utero, but I've seen it before, at least in the literature. What role do you think AI machine learning will play in glaucoma diagnosis and management? Well, that's a little bit beyond the scope of this, but I'm optimistic that utilization of AI can help with glaucoma screening and to appropriately kind of shunt fluids or shunt patients or direct patients, high-risk patients to academic centers or to glaucoma providers. It kind of help triaging patients appropriately for if something can be managed via optometrist or comprehensive ophthalmologist versus patients who require glaucoma fellowship trained patients. So optimistic about utilization of AI in diagnosis and management, but kind of beyond the scope of this this lecture. Can we give acetazolamide to children? Yes, you can. Don't really strongly recommend it, but I call pharmacy. Usually I'm giving it in the hospital. Adult dose is, at least what we orally hear, is like 250 BID, 500 BID adults, but children, I call pharmacy to children's hospital. That's a good question, but I defer that to a pharmacist so I don't cause too many systemic side effects. What is done in visual field testing in AI scan? A-scan. Visual field testing, yeah, someone answered this. I agree. Visual field testing tests the peripheral vision. A-scan measures axial length, which can get larger if the IOP is uncontrolled in children. So thank you for helping answer that question. Is the treatment of JOAG universally medical therapy first across all populations? I've come across some experts who seem to agree that for Black Africans it may be better to start with surgery. Kindly help provide some clarifications. I mean, I'm in preparing for this lecture, kind of read my glaucoma book, kind of read some articles, and I think I don't think it's hard to be dogmatic in glaucoma care. There's still a lot of nuance, and so my approach to, the corollary I'd give is my approach to glaucoma management in adult patients. I mean, sometimes I think if you minimize dependence on drops, that probably ultimately is better for patients in terms of compliance and side effects. And so in my adult patients who are amenable to minimizing dependence on drops, I kind of always push for selective laser trabeculoplasty, minimally invasive glaucoma surgery with concomitant cataract surgery and things like that. And so, I kind of gave you the textbook answer, so to speak, but I say, hey, if they're open to surgical intervention, then I say you can start with that, especially if they're open to it. In your vast experience, at what age does optic disc cupping reversal stop with IOP controlled pediatric glaucoma? I think if you initiate treatment, I believe this was discussed in the PowerPoint, IOP lowering treatment before 3 years of age, you can reverse cupping, but afterwards, you're probably not going to reverse cupping. What role do you think AI machine learning? Okay, kind of someone already asked that. I already answered that. Do you take the corneal thickness measurement in pachymetry when you check for IOP? Okay, so yeah, utilization of, pachymetry is helpful in determining what IOP, if your IOPs are overestimated versus underestimated. People much smarter than I have tried to come up with corrections, hey, if the pachymetry is this, subtract this from the IOP or that. There's no correctable factor. What I take into account is, okay, is the pachymetry very thin? Is it really thick? Is it average? And then I kind of just, okay, well, I'm measuring 21, but it's really thick, so it's being overestimated. Or I'm measuring 21, but it's very thin. Oh, that's a lot higher. And so I don't make any corrections because none of that has been really proven to be entirely accurate. What type of patient data is used to predict or detect glaucoma? Well, we kind of covered this throughout this. You go back to that, table I mentioned. So you look at IOP, cup to disc ratio, corneal to corneal enlargement, visual field, things like that. So that's, the part of that was in the Childhood Glaucoma Research Network and World Glaucoma Association grid I shared of how do you define pediatric glaucoma versus pediatric glaucoma suspect. Can CPC be considered first choice of surgery in some congenital glaucoma cases in order to postpone other glaucoma surgery? I wouldn't recommend it because cyclophotocoagulation is very pro-inflammatory and can cause a lot of conjunctival scarring, ptysis, inflammation. It really kind of wrecks the anterior chamber, in my experience, because I've had to do cataract surgery after CPCs, and very difficult in adult patients. And then also trashes your conjunctiva, kind of almost precluding sometimes conjunctival-based procedures such as trabeculectomy and tube shunt. So I wouldn't unless the patient essentially is blind in that eye and uncomfortable, and then I do it. What age should be the least to use antimetabolite glaucoma? So, I mean, if I'm doing trabeculectomy in any patient, I'm going to use antimetabolite because the blood will fail. Now, there's a procedure called orphan trabeculectomy where if a patient, we don't need to get into it, but that's the situation where if it's just a temporizing measure, you don't need long-term bleb use or success over time. You don't have to. But if I'm doing a trabeculectomy, I'm 100% of the time using antimetabolites. Now, you can adjust your concentration potentially in a child or whatnot. Typical 0.2 mg per ml concentration. So you can go down if you'd like. What factors affect the choice and type of the type of glaucoma drainage device? So I, for the most part, at least in this region, many of my patients need valved procedures because you want immediate IOP lowering. And so I would probably, I could probably discuss this with my pediatric glaucoma colleagues who do this every day. But I would think putting a non-valved GDD, glaucoma drainage device, in a pediatric patient wouldn't be really smart because there's so much nuance to the post-op care of a valved glaucoma device. So there's a suture that you might have to lyse around 6 weeks. You're waiting for this basically encapsulation of the plate. You could get hypotony. It's just so dynamic of a post-operative process that I would prefer a valved device in children personally. Maybe I'm just scared. What factors, we talked about that. Doing a scan in order to measure and compare the axial lengths, what time would it be useful from first time? So yeah, what basically is the timing for repeat EUAs, a scan, etc. Now, it kind of depends on the patient age. There's risks with repeated trips to the OR for examination and anesthesia, in terms of prolonged, anesthesia. So I mean, I've got thinking about just a couple cases I have, but some of my pediatric colleagues do. Maybe an EUA every 4 to 6 months. You just have to weigh the risk of putting the patient to sleep versus the risk of, you got to get an IOP, measure axial length, and things like that. So just depends on how concerned you are that the patient could be progressing, and that's it's very individually determined based on patient appearance, behavior, parents' concern, pressures you're measuring in the office, etc. But I would venture to say, maybe somewhere in the 3 to 6 month range for EUAs, depending on all those factors I mentioned. Risk factors during trabeculectomy, we answered that. Infection, bleeding, hypotony, scarring, phlebitis, things like that. What is the place for deep sclerectomy as treatment? Well, I don't know. I don't perform deep sclerectomies, but interested in adding it to my surgical repertoire. I'm not sure if there's a role for it in pediatric population, but certainly it's a compelling procedure for adults, and so it's something I can't answer, but I'll have to look into. So thank you for reminding me. The axial length and optic nerve injury calculator for tube shunt surgeries. Okay. So there is a calculator available, the Friedman Margetta calculator, I think is what it is. That's on Duke website. So what it is you Google search this calculator, and what you do is you input patients' kind of axial length, the tube shunt you're utilizing, distance from the limbus, and then desired distance from the optic nerve, minimum 2 millimeters. And what the calculator tells you is, hey, this is how much of the back plate of the tube shunt you need to trim so as to minimize risk to the optic nerve, like that tube shunt back plate rubbing the optic nerve. And so I use that. If the patient's got a really long axial length, a lot of times you don't need to make adjustments by trimming the back plate. But it's very helpful if you're working on a baby eye with like axial length that's not really much abnormal. And so you input axial length, input the tube shunt, input the quadrant you're implanting the tube shunt in, desired distance from the limbus, and it tells you how much of the back plate you need to trim. How long can we monitor the eye pressure of premature baby with low birth weight pathologies with drops, and what kind of drops do we use? Okay, so it's tough because child born low birth weight, you don't want to, there's risk with general anesthesia. So, but if the patient has congenital glaucoma, the treatment is surgical. And so basically, once you get the green light from pediatric service, like, okay, the risk of anesthesia are outweighed by the need for performing glaucoma surgery, you do glaucoma surgery. And so you temporize with drops. So you mentioned topical beta blockers, carbonic anhydrase inhibitors, and prostaglandin analogs are useful for temporizing. All right, knowing the 3 clinical triad is a thing and knowing no normative database for instruments is another thing. What clinical test would you carry out in a 0 to 9-month-old infant for, okay, so what would I do for a patient under 1 year of age? So, I mean, accurate history, observation of the patient, i.e., do they have tearing, blepharospasm, photophobia? Look, is there corneal enlargement? What's their pressure? And what's their optic nerve look like? And you can make the diagnosis. Pressure is the big thing, but there's other steps to diagnosing pediatric glaucoma. And then, I mean, probably hard to get like an infant to a retinal neurofibrillary scan anyways. And so I really don't do those formal tests until they're like they can cooperate in clinic, frankly. And so yeah, so utilize your exam skills to make that diagnosis and determine if they need treatment. So when you say I can do angle surgery multiple times, how many times do you think is appropriate? And do you mean performing surgery over the same area or different? Yeah, so performing over different areas. So if you do this goniotomy, typically it's an ab interno goniotomy. You do a couple clock hours. Now you can go back and perform additional clock hours in a different area. Trabeculotomy, you can do, typically you're cannulating the Schlemm's canal. A lot of times you go 360. Sometimes it can close though, and so you can bring it back and maybe try to reopen it. But I think if you're doing, namely goniotomy, where you're limited to about the visible number of clock hours if you're sitting, depending on where you're sitting. And so you can go back, bring them back and open up using goniotomy, open up more clock hours. But so that's what I mean by multiple times is you treat different areas of the angle, or if it's closed, if you did the trabeculotomy and it looked like it's sealed, then you can repeat it. So I don't know, there's not like a maximum number of times, but maybe like if you tried angle-based surgery twice and you're still getting high pressure, it's probably time to move on. What drug is the first-line choice for congenital glaucoma? We mentioned you can consider beta blockers, carbonic anhydrase inhibitors, prostaglandin analogs. I typically start with beta blockers. What is the dose of acetazolamide given to children? Call your pharmacist. I don't know. A lot of that depends on birth weight and their current weight. And so lowest possible dose. In general, if the general condition of the baby doesn't allow for eye surgery, what medication regimen do you prefer to use till time of surgery? Topical beta blockers, carbonic anhydrase inhibitors, prostaglandin analogs. Would you advocate for external trabeculotomy in 2 areas as a first surgery? Yeah, I mean, so I think, yeah, you can do goniotomy, couple of clock hour goniotomy. You can do ab externo trabeculotomy doing just 180. That's fine. It's very customizable. And so it might be a little bit tricky to do ab externo trabeculotomy in just 2 clock hours because of the way you have to do it. So you might need to have visualization of the angle so you could do it ab interno. But yeah, essentially you can treat however much it makes sense to. I would probably, my default would probably be 360 just because if you're going ab externo, that implies you probably don't have a good view through the cloudy cornea. And so treating 360, you're cannulating it through, comes all the way through the, that end of the catheter or suture, and you just pull both ends, and then you got 360 treatment. So, all right. Do you consider the rate of axial length increase to assess glaucoma progression to children? Yeah, for sure. So, there's age-appropriate axial lengths. Offhand, I can't think of them, but if there seems to be a progressive increase in axial length out of proportion to age expected values, you better be watching that pressure. How common is angle closure glaucoma in children? That's beyond the scope of this discussion, and frankly, I don't know. I'd have to look that up. Is it really safe to use cycloplegics for patients with primary congenital glaucoma to monitor myopia? I don't know. I don't know the answer to that. I don't typically treat as I primarily focus on glaucoma treatment in my practice, and so I can't speak to use of basically atropine and kind of drop-related amblyopia treatment. So I'm not sure, but yeah, I'm not sure if I can answer that question. What age do you start asking for OCT nerve? Well, the age at which they're able to come to the slit lamp, and so that depends on the child. Many times my little girl patients are a little bit more cooperative than the little boy patients. I don't know what it is. And so, yeah, usually try around 5 or 6. If they're able to come to the slit lamp, like with over a period of multiple visits, then they can usually go up to our Heidelberg OCT. What are your thoughts on trabeculotomy combined with trabeculectomy? Works very well. And what antifibrotic agent regimen do you use in TRAB? Mitomycin 0.2 mg per ml. Volume, I think I do 0.1 or 2. I combine it with lidocaine. So I would do it the same as my adults unless I was concerned sclera looked thin or whatnot. So I'd probably just default use the same concentration, but it's customizable. I have many cases with large cupping discs with no other signs of glaucoma. How do I follow these patients? Could be physiological cupping. And how to differentiate in cases of high myopia and cupping the disc? How to define whether increasing axial length? Yeah, it's so tricky. Myopia and glaucoma, it's so tough. I actually have a different cybersite lecture on that. It's tough. And so, you know, it's just weighing the risks and benefits of initiating treatment or not, pressure lowering treatment, what's their follow-up ability, can they come for serial exams on the regular to monitor. You know, it's a very individualized approach when it comes to patients with high myopia and you're concerned about glaucoma. But the myopic discs are very difficult to interpret. I feel you with that one. Can untreated congenital glaucoma result in nystagmus in the long run? Untreated congenital glaucoma can result in buophthalmos, corneal clouding, low vision, which can result in kind of sensory nystagmus. So yeah. Do the normal glaucoma assessment tests on infants? Yes. Yeah. So tough to do any sort of testing on infants, but how do you diagnose glaucoma? You look at the optic nerve, you check the pressure, you measure the corneal diameter, and then yeah, that's usually enough to make the diagnosis of glaucoma. And that's based on that chart I showed at the beginning, the Childhood Glaucoma Research Network and World Glaucoma Association chart for diagnosing pediatric glaucoma versus pediatric glaucoma suspect. Must all tests be done for pediatrics, especially when it's congenital? No, not necessarily. I gave like kind of an all-inclusive list of things you want to monitor, which include, of course, exam, measuring, you know, the exam portions are critical. But with regards to, you know, do I need to do a visual field in RNFL every visit? Well, no, it's individualized. Cycloplegic refraction is very important in the pediatric population, monitoring for amblyopia and the like. Please comment on the management of pediatric uveitic cataract during glaucoma. Well, we didn't really talk about uveitis or cataracts, but uveitis can cause glaucoma, and congenital cataracts, as we talked about, can cause glaucoma. So lots of different modalities in which you can develop glaucoma. You have to be sure to treat both conditions, underlying uveitis, cataract, and then glaucoma. So I kind of a little bit beyond the scope of that, so that's a limit to my answer there. What's the pathophysiology of aqueous outflow obstruction congenital glaucoma? You tell me. We don't know. Markhan's membrane has never been proven, but it's some sort of anomaly of the angle. And so, okay, mechanism of action of the cyclodiode laser. CPC laser, you're applying energy to the ciliary body, and it results in IOP lowering. Very pro-inflammatory. We are out of time. Oh my gosh, I didn't mean to go this long, but thank you, everyone. I appreciate your wonderful questions, and thank you for joining. This will be available later as this recording, and if you have any questions, you can reach out to me, and please utilize the CyberSite mentoring platform. Thank you so much.